Welcome to the second unit of endocrine disorders. In this unit, we're going to be talking about the adrenal disorders, the parathyroid gland disorders, and the prolactin disorders. And let me start with the adrenal gland disorders. Where is your adrenal gland? Well, it is adjacent to your renal tissue. Where is your renal tissues? Your kidneys. And the adrenal gland is a triangular gland on top of your kidneys. We have two adrenal glands, and each adrenal gland has a central core, or the medulla, out of which comes epinephrine and norepinephrine, but we're going to be talking about the adrenal cortex. The major hormone of the adrenal cortex is cortisol. Also, the adrenal cortex secretes aldosterone, that is a mineralocorticoid because it deals with minerals, so sodium and potassium. Aldosterone is save sodium, P potassium. Let's keep sodium in the body and let's get rid of potassium. That's aldosterone. Whereas cortisol is the hormone of chronic stress. Cortisol will increase the blood glucose. Cortisol will turn everything in your body into glucose to make glucose available for the brain in times of stress. Cortisol is one of the stress hormones. Cushing syndrome, or too much cortisol, hypercortisolism, it's any form of hyperadrenalism, no matter what is the cause. Any form will have a common clinical presentation consisting of the following. Abnormal fat distribution. What do we see in Cushing syndrome? Truncal obesity, moon face, buffalo hump, thin arms and legs. Why thin arms and legs? Because cortisol is going to go to these muscles. Come on, give me your proteins. Why? I want to convert it to glucose. And you get thin muscles, thin arms and legs. Easy bruising and striae because of loss of the collagen from the skin. Again, because cortisol is going to turn your collagen from the skin into glucose. Hypertension, because too much cortisol, when you have excess cortisol in abnormal pathological amounts, cortisol will also have a mineralocorticoid activity and will lead to salt and water retention, and this will increase your blood pressure. Also, cortisol will result in alpha receptor upregulation, and this will make your blood vessels so responsive to the sympathetic stimulation and will be constricted, and your blood pressure will go up. Muscle wasting, hirsutism, because when you have too much cortisol is going to acquire some androgenic effect, abnormal increased adrenal androgenic levels. And osteoporosis, again, because cortisol is going to convert the proteins from your bones into glucose, and this is going to weaken your bones. So cortisol, it increases the glucose levels by gluconeogenesis. It breaks down proteins to amino acids which are used to make sugar. Specifically, bone and skin proteins are broken down and made into sugar, and this will lead to bruising, striae, muscle wasting, and osteoporosis. Too much cortisol can result from three conditions. Either you have a pituitary tumor that's secreting too much ACTH. What's the ACTH? Adrenocorticotropic hormone. It's the hormone that comes out of the anterior pituitary to stimulate the adrenal cortex to release cortisol. If you have a pituitary tumor, it's going to secrete too much ACTH. This will lead to too much cortisol. Sometimes you can get this abnormal too much ACTH coming from an ectopic focus, not the pituitary. Normally, ACTH should come only out of your pituitary. Some conditions you can have ectopic ACTH production. Sometimes it's not about the ACTH at all. Too much cortisol is coming out of an adrenal adenoma. You have an adenoma in your adrenal gland, and this adenoma is secreting cortisol. How to differentiate between these three sources of hypercortisolism? Well, in pituitary tumors and in ectopic ACTH, the ACTH level is going to be high. But in adrenal adenoma, the ACTH level is going to be low. So whenever you have a Cushing disease and the ACTH is low, a patient with a Cushing syndrome, and the ACTH is low, you know that the lesion is in the adrenal gland and not elevated ACTH. When you have this, we can do what's called the high-dose dexamethasone suppression test. What's this test? This test means, normally, if I give you dexamethasone at night, the level of cortisol should be suppressed in the morning, should be lower in the morning. This is not seen except with pituitary tumor. So with pituitary tumor, the ACTH level will drop and the cortisol level will drop in the morning when I give you high dose dexamethasone in the evening last night. So it is positive only in pituitary tumor where you don't get any suppression in ectopic ACTH and in adrenal adenoma. Some specific tests for the pituitary tumor: you can do MRI, you can do petrosal vein sampling, you can measure the level of ACTH in the petrosal vein that comes out of the pituitary. If you have too much ACTH in it, this is definitely a pituitary tumor. Ectopic ACTH production usually comes from tumors in the chest and abdomen, so scan the chest and abdomen. Adrenal adenoma, scan the adrenals. And the treatment will be the same for the three of them: remove the adenoma, remove the tumor, remove the cause of increased ACTH. So, how to diagnose Cushing syndrome? You're going to suspect Cushing syndrome by the clinical manifestations. You're going to have some lab abnormalities also added to the clinical manifestations. You're going to have hyperglycemia because it's all about increasing the blood glucose, and hyperlipidemia, osteoporosis, leukocytosis, and metabolic alkalosis. Metabolic alkalosis, why? Too much aldosterone, safe sodium, P potassium, and acid. And when you P acid, you're going to get metabolic alkalosis. The diagnostic testing, as I said, the best initial diagnostic tests are overnight dexamethasone suppression test and 24-hour urine cortisol. Actually, we have to start with the 24-hour urine cortisol. It's more accurate, it's better than the dexamethasone test. So we should start with it first. This test is going to tell you what? It's going to tell you, hey, you have too much cortisol. But it's not going to tell you where is it coming from. The 24-hour urine cortisol is going to diagnose hypercortisolism. When this is high, then you have to do what? You have to do the overnight suppression dexamethasone test. What do we do in this test? A normal person will suppress the 8 a.m. level of cortisol if given dexamethasone at 11 p.m. last night, the night before. A normal test excludes hypercortisolism of all kinds. If you have normal test, this is going to exclude hypercortisolism. Abnormal test can still be falsely elevated from various stresses such as depression, alcoholism, emotional or physical stress. This means what? You can have high cortisol levels in the morning despite your dexamethasone if you have some physical stress. That's why we should always start with 24 urine cortisol. Start with 24 urine cortisol level if it is elevated, so you know for sure you have hypercortisolism. Do the dexamethasone suppression test, get back to the table. The pituitary tumor will suppress the cortisol level if it dropped after this dexamethasone test. This is going to diagnose pituitary tumor. If it did not drop, then it could be coming from an ectopic ACTH, or this cortisol could be coming directly, from the adrenal adenoma. So, again, the diagnosis of Cushing syndrome. How to make sure that this patient has hypercortisolism. 24-hour urine cortisol will tell you you have too much cortisol. Where is it coming from? What's the test to tell you? The overnight dexamethasone suppression test. Give a dose of dexamethasone at 11 p.m. and look at the cortisol level at 8 a.m. If the cortisol level is suppressed, is low, you know that the cause is in the pituitary. If the cortisol level is not suppressed, then the cause is not in the pituitary. It could be ectopic ACT production from a tumor in the chest or abdomen, or it could be an adrenal adenoma. So again, the diagnostic testing for Cushing, 24-hour urine cortisol test to diagnose the presence of hypercortisolism, and then determine the cause by suppression test. If you have a low ACTH level, this means that the lesion is in the adrenal gland, so scan the adrenal. If you have high ACTH level, this could be coming from a pituitary adenoma or could be coming from an ectopic production of ACTH. Then the next step is doing what? High dose dexamethasone suppression test. It will only suppress the pituitary ACTH. If it does not suppress this high ACTH, then look for something in the lung or in the abdomen, some ectopic focus secreting ACTH. Treatment of hypercortisolism. The treatment is going to be always remove the cause, remove the adenoma. If the high dose dexamethasone suppresses the ACTH, then look for the pituitary. Scan the pituitary, make sure that you have a pituitary adenoma, and then remove it. If the high dose dexamethasone does not suppress the ACTH, look for the source of ACTH. It could be any tumor in the chest or abdomen. Scan the chest and abdomen, scan the chest for lung cancer or carcinoid, and remove cancer if possible. Our case study for Cushing syndrome. We have a 35-year-old woman who presents complaining of a dull, persistent headache, significant weight gain over the past 6 weeks, significant facial hair growth, menstrual abnormalities, and both an excessive thirst and appetite. She also feels very depressed and does not have much energy. Blood pressure was found to be 185/105. That's very high blood pressure. So what's the most concerning about her vital signs? Of course, her blood pressure. That's dangerously high. Identify the abnormal lab test results in this case. Well, we have elevated fasting glucose level. We have elevated ACTH. We have elevated serum cortisol, urinary free cortisol. We have serum testosterone elevated. Arterial pH are all significantly higher than normal, abnormally high. Serum potassium is low. Lymphocyte fraction is low at the expense of the relatively high neutrophil fraction. Cortisol inhibits cell division of lymphocytes in lymphoid tissues. Do lab test results suggest that hypercortisolism in this patient is ACTH dependent or ACTH independent? Lab results here suggest that this hypercortisolism is ACTH dependent. ACTH dependent. Why? High levels of ACTH and testosterone are consistent with ACTH dependent Cushing syndrome. That's why the ACTH is high, and this is the cause of elevated cortisol. If Cushing syndrome was ACTH independent, then the ACTH concentrations would be low due to the negative feedback of cortisol on the hypothalamus and the anterior pituitary. Is the hyperpigmentation of the skin and gingiva noticed in this patient more characteristic of ACTH dependent or ACTH independent Cushing syndrome? Hyperpigmentation will always be characteristic of ACTH dependent, and this is the reason. ACTH comes out of the anterior pituitary, and within the same package comes out with it MSH hormone. What's MSH? Melanocyte stimulating hormone. So whenever the pituitary produces too much ACTH, you're going to have too much MSH, and this will lead to skin hyperpigmentation. What is the treatment of choice for curing hypercortisolism in this patient? If a tumor is discovered in the pituitary gland, remove it. Surgical resection.